So hardly anything left. In fact, I can go through very quickly. Malnutrition is a very common problem which we encounter in cirrhosis, and it increases risk of morbidity, mortality. Prevalence varies from 5 to 99% depending on the stage of disease. This is potentially modifiable condition, so a nutritional therapy or intervention may be required. And nutrition screening and assessment are infrequently performed. This is also one of the problem area because there are no validated rapid screening tools, and multiple definitions of what constitutes malnutrition also exist in the literature. If you go through various papers, you will find number of definitions of malnutrition. Challenges with interpreting body composition and laboratory results in the setting of volume overload and liver dysfunctions may also influence. So what are the definitions? Malnutrition there is a theoretical definition and an operational definition. It's a clinical syndrome that results from deficiencies or excess of nutrient intake, imbalance of essential nutrient, or impaired nutrient use. And what is the operational definition? An imbalance means deficiency or excess of nutrients that cause measurable adverse effect on tissue, body form, or function, or clinical outcome. And what is frailty? It's a clinical state of decreased physiological reserve and increased vulnerability to health stressor, and rest of the things, in fact, sarcopenia and frailty have already been discussed at length. So how this frailty and sarcopenia is affected and actually impacted with the malnutrition, that also we know, and this has also been discussed at length in previous two talks. Inadequate intake of macro and micronutrient, inadequate uptake of micro and macronutrient, and excess intake of macronutrient all can lead to malnutrition, and this can lead to frailty or sarcopenia, along with disease-related factors like in cirrhosis, there is synthetic function is impaired. There may be fluid retention, cognitive dysfunction, hyperammonemia. Hyperammonemia is very important because it upregulates myostatin, which in turn lead to upregulation or downregulation of mTOR pathway, which is a very important pathway for muscle synthesis. Then there may be anabolic resistance in cirrhosis. So there is accelerated starvation and anabolic resistance. So there is less of protein synthesis. And it also depends on etiology of liver disease, because in alcoholics, you find malnutrition quite in a significant number of patients. There are other systems that was also discussed by Dr. Anand at length. So I'll not go into the details, and ultimately it leads to increased decompensation, increased healthcare utilization, decreased health-related quality of life, death, and adverse post-transplant outcome. So this, this has also been discussed, that malnutrition is associated with increased risk of morbidity, mortality, compromised immune function, increased recovery time, delayed wound healing, longer hospital stay, increased complication, and this is also associated with increased complications in form of encephalopathy, bacterial infection, recurrent ascites, and mortality and morbidity in the post-op period. So prevalence of malnutrition also varies depending on the stage of the disease. As the chronic disease advances, you find initially it may not be there. In compensated cirrhosis, it is around 20%. And in decompensated cirrhosis, it is 60 to 90%. These are the screening tools. Once a patient with malnutrition is there, or any cirrhotic, you use nutrition screening tools to assess the nutritional status. These are few which I have mentioned here. One is, which is used in community, MUST. It incorporates three important parameters: BMI, unplanned weight loss in past 3 to 6 months, and acutely ill and unable to eat. So these three features can give you an idea whether the patient needs a nutritional assessment or not. Same way, in a hospitalized patient, you can use NRS 2002 or Nutric score. Nutric score generally we use in critically ill patients admitted in ICU, and we take care of 6 parameters, and on the basis of that, a score can be obtained, and we can assess whether the patient's having malnutrition or not. This is for global malnutrition. You use global assessment tool in cirrhosis, and There are certain subjective features and subjective parameters and few objective parameters. The subjective are 5: weight change, dietary intake, gastrointestinal symptoms, functional capacity, and metabolic stress of underlying diagnosis. And physical examination parameters are loss of subcutaneous fat, loss of muscle mass, edema, and ascites. And when, on the basis of this, we decide whether the patient is well-nourished, moderately malnourished, or severely malnourished, and then we can use other methods of assessment of malnutrition. So we assess micro and macronutrients. The purpose of assessment is to identify patients who will benefit from nutritional support, and any method of assessing nutritional status need to ideally fulfill the following criteria. It can predict the development of complications resulting from malnutrition, identify the risk of developing malnutrition or malnutrition in early stage so that prophylactic nutritional therapy can be given, and distinguish between protein energy malnutrition on one hand and cachexia and age-related changes on the other. So for dietary assessment, we have, as we have discussed, after screening, a nutritional assessment should be performed in patients at high nutritional risk to confirm risk assessment, characterize nutritional status, and identify modifiable variables, as I have already said. And regardless of these tools, in fact, there are certain clinically relevant information which should be obtained. And then assessment is focused on macronutrient deficiency and micronutrient deficiency as well. Because in patients with cirrhosis, you will find micronutrients are also deficient. Their zinc and magnesium deficiency may be observed as a consequence of diuretic use and restricting animal proteins. Then frequently, we also encounter fat-soluble vitamin deficiency, especially vitamin A and D. In them, vitamin D is low. So, and there are very few guidelines to suggest how frequently we should reassess. But in case micronutrient deficiency is not there in the beginning, we can do it on the yearly basis. This is our own data where we have shown that micronutrients are deficient in cirrhosis and that this deficiency increases with the severity of the disease. Then vitamin D level, that is also less, but interestingly, we have given an intervention of vitamin D in these patients for 1 year, and there was no change in the parameters or bone health. Then there are other biochemical parameters which can be used for assessment of nutrition, like albumin, CRP, or prealbumin, but these are affected by liver disease per se and excess alcohol intake and inflammatory state, so they lose their sensitivity and specificity, especially in liver disease. Then branched chain amino acids are critical for muscle synthesis. In fact, essential amino acids, including branched chain and methionine, are typically low in sarcopenia, and deficiency of leucine lead to decreased activity of mTOR signaling pathway responsible for protein synthesis. These are investigations for assessment of sarcopenia. There are certain tools which are research tools, and there are certain tools which we can use in clinical practice like BIA, DEXA, anthropometry, especially mid-arm muscle circumference, and CT at L3 for SMI. These, in fact, have already been discussed by 2 speakers. So, as far as body composition is concerned, you know the BMI, the cutoff WHO criteria for BMI, who are obese, who can be said as normal or overweight. This is well known to everyone. The only fallacy is in case of ascites and edema, when it is present, we have to calculate BMI from estimated dry weight or define cutoff for diagnosis of malnutrition according to the presence of ascites. So cutoff of values can be 22, 23, and 25 kg per meter square in normal, moderate, and tense ascites. We reduce around 10% of the body weight if moderate ascites, 5% if mild ascites, and 15% when severe ascites. And pedal edema, we add 5% extra. Then these are the methods to assess fat and muscle mass. We use anthropometry for that. This is for triceps skin fold thickness and mid-arm muscle circumference. And then these measurements are useful in population studies and reliable in patients reliability is less clear. This has been shown that consequence of malnutrition and effect on survival when mid-arm muscle circumference was studied, then it has been shown that if muscle mass is less, that affects the survival. Then BIA, it estimates body fluid volume by measuring the resistance to a high frequency, low amplitude alternate electrical currents. So in healthy adult, it is possible to predict total body water within 2 to 3 liters. Patients who had a low fat free mass were more likely to have a longer duration of stay in hospital. It is relatively inexpensive, quick, reproducible, but lacks credibility in ascites and edema. Same is true for DEXA also. CT and MRI, as has been said, it is the gold standard. Various cutoffs has already been discussed. Now, sarcopenic obesity and myostasis, this has also been discussed, and the effect on outcome has also been shown. This is how we function. We study muscle function by hand grip dynamometer. And now comparing all these modalities, we can say that anthropometry, the accuracy is low, but it is very simple. But there is marked inter-observer variability. BIA, again, this is influenced by volume status, requires special equipment. Ultrasound, we rarely use it for routine assessment. DEXA, the accuracy is high, but radiation exposure and high cost is the limiting factor. CT, again, the accuracy is very high, and it allows assessment of muscle mass, but radiation, contrast exposure, and high cost are the limiting factor. MRI is as good as CT scan. So we know that what type of biomarkers we need. We need a biomarker to assess the strength, quality, and function. These all things have been discussed. We can easily skip. So these are the various cutoffs which have been given by various groups and by various working groups, including INASL. And then we carried out study in our own cirrhotic patients. Out of 271 patients, in fact, if we use Asian cutoffs, the prevalence of sarcopenia goes down significantly. But if we use Western cutoff, then sarcopenia is very high. And when we compared various cutoffs, there is very low, in fact, concordance in them. These are the tests for frailty and sarcopenia. This again been discussed in detail by the first speaker. And this is the cutoff and diagnostic criteria which we use for diagnosis of sarcopenia, frailty, and malnutrition. So what is the prevalence and natural history of frailty? It's common among patients with cirrhosis. Prevalence increases with liver disease, varies because of use of different tools to capture impaired muscle contractile function. In ambulatory setting, prevalence is 17 to 43%, hospitalized patient 38%, with encephalopathy little more. After liver transplant, 90% experience some improvement in their KPS score, and median improvement of 20% by 1 year. At 3, 6, and 12 months after liver transplant, liver frailty index score worsened from pre-transplant values in 59%, 41%, and 32% of patients. As far as association with outcome is concerned, we know that carries a bad prognosis, and this has already been discussed by Dr. Anand in detail. So as far as guidance statement is concerned, there are insufficient data to recommend the use of one frailty tool over another. In patients with compensated cirrhosis, annual frailty assessment may be sufficient, whereas patients with decompensated cirrhosis, they may benefit from more frequent assessment. Patients should be counseled on the adverse consequences regardless of baseline frailty status, and testing will be particularly useful in ambulatory setting. These are the various studies. And in sarcopenia, change in physical fitness have been strongly correlated with adverse outcome. Here also, change in skeletal muscle mass has been strongly correlated with adverse clinical outcome, mortality, ICU stay, and length of stay. This has again been shown by Dr. Anand hardly anything new in it. This is also meta-analysis of 19 studies in 3,803 patients of end-stage liver disease, where it has been clearly shown that skeletal muscle mass has a definite bearing on the outcome. These are the two recent meta-analyses which have included 47 studies and 8,850 patients. 32 definitions on malnutrition were utilized in these 47 studies. So you can well imagine how much is the discrepancy in these definitions which exist in the literature. Nutrition assessment tools predict pre-transplant mortality in 69% of cases and are prognostic for post-transplant mortality only in 28%. This was the second one in which 38 articles were included. In adults, the prevalence rate of pre-LT sarcopenia, liver transplant sarcopenia, was 14 to 78%, and sarcopenic obesity was 2 to 42%, and post-LT sarcopenia was 30 to 100%, and obesity was 88%. The presence of pre-LT sarcopenia is associated with higher waitlist mortality, greater post-op mortality, higher infection rate, and post-op complication. So when we suspect sarcopenia, we can do a hand grip testing. If it is abnormal, then sarcopenia is likely. If it is normal, then we can say that sarcopenia is not present. Then we assess muscle mass. If it is abnormal, sarcopenia is confirmed, and then we do various tests to assess the severity of sarcopenia. And this is the last slide, how we proceed. This is the easel consensus slide here. If a patient is having malnutrition, we assess the child status of the patient depending on the BMI. If a patient is underweight or if patient is having BMI of less than 18.5, then he is at high risk. That patient should be assessed for sarcopenia with the help of a CT, DEXA, or BIA. If sarcopenia is present, we can proceed accordingly. If a patient is at medium risk, again, we do a detailed nutritional assessment by subjective global assessment. And then we take the history of dietary intake. If there is malnutrition, we again do DEXA or CT scan. If there is no malnutrition, we can repeat it after 1 year.